Well, good morning, everybody. I am excited to.
Thank you for coming. Welcome to NATO's 38th Annual Conference. We will be starting in about 1 minute. Before we begin, we want to cover a few housekeeping items. On your attendee screen, you can enter comments in the chat and questions in the Q&A. We hope you will take advantage of this opportunity to engage with our speakers and attendees. This session is being recorded. We recognize and thank the California Healthcare Foundation for being our Petabyte sponsor. Information about all conference sponsors is available in the sponsor area of the platform. Please take a few minutes to visit each sponsor's booth where you can find information about them and find game tokens. Game tokens are keywords or phrases used in the token hunt game for a chance to win a prize in our daily drawings. Now, let me turn the stage over to Norm Thurston, NATO's Executive Director. Norm, the stage is yours.
Oh, thank you, Erica. Thank you. And we're ready to start now. A little hiccup there at the beginning, but we are ready to go. I am pleased to welcome you to this session, Advancing Health Equity, Data-Driven Approaches to Social Determinants and Disparities, and especially want to thank our sponsor for this session, which is Comagine Health. We're going to just hear a few words from Sarah Halvik from Comagine Health. Sarah, go ahead.
Hi, I'm thrilled to announce this next session, Advancing Health Equity, Data-Driven Approaches to Social Determinants and Disparities. My name is Sarah Halvik, and I am the Vice President of Data Solutions at Comagine Health. Comagine Health is a national nonprofit healthcare consulting firm, and this year we are celebrating 50 years of partnership with providers, patients, community organizations, government agencies, health plans, and many others to improve health and healthcare in the United States. This work is inspiring and meaningful to me because I believe that if we are truly going to improve health and healthcare in the US, we need to start with data-driven approaches to social drivers and disparities. Every person deserves to be seen and appreciated, both going through their daily lives and in the health data that are used to design and evaluate services and programs. If we cannot see every person in the data, we cannot address disparities that lead to worse outcomes for some and better outcomes for others. High-quality granular data on personal characteristics is a great starting place. The gold standard of high quality is both self-reported and standardized, so that every person is accurately represented and the data can be aggregated for population health use cases. Capturing whole person health drivers is also critical to achieving equity. This includes consideration of medical needs in addition to emotional, dental, environmental, and social needs. Of course, medical diagnoses are important, but so are housing, food, transportation, childcare, safety, education, and more. Z-codes are a step in the right direction to capturing and addressing whole person health drivers. I want to say thank you to NATO, session organizers, moderators, and speakers for the opportunity for Comagine Health to provide this introduction. So without further ado, let's get on with the session.
Thank you, Sarah. Thank you for your kind words and your remarks. We are now going to turn the time over to our moderator for this session, Katie McGraves-Lloyd. Katie, if you can join me on stage. Are you ready to go?
Yeah, let's go.
Okay, let's.
All right, thank you. Thanks everyone for joining our session. Let's get into our first presenter. Our first presenter is Danny Saunders. She's a data scientist at HSRI. Danny?
My name is Danny Saunders, and I'm a data scientist on the population health team at the Human Services Research Institute. And today I'll be going over my project with you, which is addressing disparities through data quality, the development of person-level race and ethnicity composite attributes from data submitted to the main health data organization. So this is my agenda. I'll give you an overview of MHDO and the data sets, and then I'll discuss the different federal standards when it comes to reporting race and ethnicity information. And from there, I'll go over the assessment process results as well as lessons learned. So the Main Health Data Organization, or MHDO, is an independent state agency charged with creating and maintaining a useful, objective, reliable, and comprehensive health information database that is used to improve the health of Maine citizens and to promote the transparency of healthcare costs and quality. So MHDO houses two statewide data sets. It houses the statewide all-payer claims data set, or APCD, which captures nearly 90% of insured individuals. They also house the hospital encounter data set, which includes inpatient and outpatient hospital records for hospital systems across Maine. And this data set encompasses about 77% of Maine's population and includes information on uninsured individuals. However, this data set excludes self-funded Employee Retirement Income Security Act, or ERSA plans, unless that information is voluntarily reported. The analysis that was performed builds on efforts to assess progress towards collecting race and ethnicity data in Maine, which was codified in public law in 2021 under Chapter 34, and aims to understand the impact of differences in data submission requirements at the individual level, with the overall goal of supporting efforts to address health inequities. When it comes to defining race and ethnicity, race is a social definition reflective of people with similar physical characteristics and culture, and ethnicity is defined as a categorization based on ancestry and identification of shared experiences with the particular culture or group. When it comes to federal standards in defining race and ethnicity, these are social political constructs that are not intended to be representative of biological differences between groups, with ethnicity being representative of whether or not someone comes from a Spanish-speaking country. In 1977, the Office of Management and Budget, or OMB, established a minimum standard for the collection of race and ethnicity information for federal surveys. And these standards are included here on the slide. So these are the information needs to be self-reported with multi-select options available. And at the very minimum, these 5 racial groups should be presented, and at the minimum 2 ethnic groups. The slide you see here is showing you how the MHDO submission requirements for each of these data sets compared to the federal standards. Starting in 2021, the APCD basically checks all of the boxes. However, the hospital encounter data set, we have data back to 2007 for that data set, and all of the boxes are checked except for the ability to include 2 or more races when applicable. That was done for race and ethnicity was performed twice, with the second time encompassing an additional year of data. MHDO utilizes de-identified person IDs to merge unique individuals in the data warehouse across these data sources, which is populated for data submitting beginning in 2017 for the APCD and 2018 for the hospital encounter dataset. Data from the APCD for the analysis was based on month-level records from medical, dental, and pharmacy data for 2021, with the second iteration expanding to information from 2022. And data from the hospital encounter dataset was based on inpatient and outpatient hospital visits with discharge dates between 2018 and 2021, with the second iteration expanding that range to 2022. And using this de-identified index key or person ID at the individual level, data from both of these databases were linked, and data availability and consistency for these de-identified individuals was examined within and across these data sources. The slide you see here shows the results of the consistency and availability for the race ethnicity information for these data sources. Availability was defined as that de-identified person ID with at least 1 valid field entry based on data submission rules, which are Chapter 243 for the APCD and Chapter 241 for the hospital encounter dataset. And consistency was defined as a de-identified person ID having valid options 100% of the time after unknown or refused to answer options are eliminated. And since the hospital encounter submission layout does not currently have the ability to include multiple races, for individuals that had been identified as multiracial in the APCD, this calculation was modified so that at least one of the race options had to match 100% of the time. When it comes to looking at the data availability, as you could see in looking at the APCD data alone, it was only populated 36 to 50% of the time, and it is primarily representative of the main care or Medicaid population. However, for those individuals, when that information is combined with the hospital encounter data set, that percentage then jumps up to 79 to 80%. And in looking at hospital encounter data availability, generally speaking, that information seems to be available 98 to 99% of the time when information is looked at alone or in combination with the APCD. And then when it comes to looking at the consistency of race and ethnicity information, if you're looking at race alone, ethnicity alone, or race and ethnicity together, data is relatively consistent. When it comes to actually drilling down further into the specific race and ethnic categories, what you see here on this chart are the results of the consistency proportions for those. So as you can see, when it comes to white, non-Hispanic, information is relatively consistent within both of these different data sets. However, when it comes to looking at different minority populations like American Indian or Alaska Native, Native Hawaiian, Pacific Islander, and even Hispanic, the consistency is much lower for hospital encounter From the assessment, we essentially wanted to use the information to populate race ethnicity categories in a person directory that was developed. This person directory, the goal is to have this data object be available for MHDO data users at request. That includes curated demographic information for individuals. So the way that object is set up is that each row is intended to be representative of one distinct individual, with columns being representative of the different demographic characteristics for that individual. So some of the options when it comes to adding in race and ethnicity for this person directory include what you see here on the screen. So one of the options we looked at was rarest race, which essentially prioritizes the less common racial groups first when assigning a distinct race and ethnicity value. Another option we looked at was the most frequent race and ethnicity reported for an individual. And another option we looked at was the most recent race and ethnicity being reported for an individual. However, instead of utilizing one of those specific categorization options, we decided to come up with a custom logic based on the information that we were actually seeing in the data warehouse. So what you see here is the Cliff Notes version of the logic that was implemented for populating the race and ethnicity fields. The overall goal was to prioritize good data and then offer flexibility to MHDO data users. So one of the first decisions we made was to apply a rolling 5-year data rule. So that way we could eliminate bad data over time if there's any potential data entry errors or things like that. And the second decision we made was instead of having a singular column for race and a singular column for ethnicity or a singular column for both, we decided to include columns for each of the different OMB categories with additional columns for other race, and unknown ethnicity. From there, we implemented kind of a stepwise logic for filling in the information for distinct individuals. First, we set aside rows of data where the only information that was available was other race, unknown, or race refused. The remaining data was then put into 2 different buckets based on submitter history. Since we know that certain minority populations are inconsistently available for individuals, we decided to separate this information into the 2 different buckets. The first bucket included information from submitters that had a known history of reporting on all minority populations. And the second bucket was the other remaining submitters. So that first bucket was then used to populate each of the race and ethnicity categories if it was ever present in the data. And for individuals that did not have information applied during that step, the information from the second bucket was then applied to those individuals. And then from there, for remaining individuals that had row level data that only consisted of other race, then that information was also applied. In doing our data quality assessment, it was identified that there would be instances where an individual was then identified as both Hispanic and non-Hispanic. And compared to racial categories, which could be multi-select, ethnicity is usually an either or type of category. So then we applied a rule to defer to the rarest ethnicity, in other words, Hispanic. And then for all remaining individuals that didn't get populated from any of those data steps, then unknown race and unknown ethnicity were populated. From there, we also decided to implement a few different flags that could be used by data users. One for multiracial, as it was identified in the row level data, or the APCD. We added in a flag for multiracial as a result of the aggregation of the data. And then we also added in a flag for individuals where their most recent data point was race. The slide you see here is essentially showing you the demographic breakdown for each of the different data sources for individuals that fell in the 2022 data set. So it's showing you how it looks for the APCD, the hospital encounters, as well as the updated person directory and how that information compares to the census. So generally speaking, as you can see with our de-identified person directory, the proportions of people that fell into the different demographics are relatively comparable to the most recent census data. As for lessons learned, there are 2 major lessons. Data is only representative of the collected and submitted information. The categorization options offered to individuals at the data collection level is currently unclear at this time. And OMB standards were determined years ago, so the data collection rules are reflective of the categorical decisions that were made at that time. So thank you so much for hanging out with me. If you have any questions or concerns, feel free to reach out. I look forward to hearing your questions later.
Great. Thank you, Danny. It was a very informative presentation. Charles mentioned that there was a question in the Q&A tab. I haven't been able to see that, Charles. Are you able to pull that up on the screen? Here we go. So question for you, Danny, also on the screen. What % of the race data falls into the not reported or other category?
Yeah, I'm looking at the Q&A right now, and the restated question for what % of members were dropped because of race was unknown, race refused, or other race. Members weren't actually dropped from that. Like basically, those individuals are still in the person directory. They're just, if no information was available for them, the flags for unknown race and unknown ethnicity are flagged for them, basically. So no one gets eliminated. No one got eliminated from the logic.
Great, thank you. Great. I don't see any other questions from the audience, but I had a couple questions. So Danny, could the logic that you applied here be applied to other data sets?
Yes and no. The decision points, the different decision pieces that were made along the process of, like, for example, should you do rarest race for ethnicity kind of thing, those types of logic steps could be applied to other data sets, but since this was very custom to the data and submitter information that's specifically available in this data warehouse, unfortunately, it also cannot be universally applied.
Sure, makes sense. There's some nuance, yeah. Another question, what could lead to inconsistent reporting on racial and ethnic groups?
Yeah, the data collection at the ground level. Like, I know anecdotally from my experience, like when I go to a hospital and I like receive a form or something that asks for my demographic information, if you look at, like, for example, what those categories are, sometimes, for example, people will merge like Native Hawaiian and Pacific Islander with Asian. So not having standards at the ground level for what information needs to be collected, I feel like definitely contributes to different data discrepancies.
Yeah, it makes sense. Great. And then I had one more question. Are there gaps in information that's captured by the MHDO warehouse?
Yes. So the data from the VA and data from the Indian Health Services does not get incorporated in these data sets. So I do believe that the American Indian Alaska Native population in particular is probably underrepresented. And then again, VA folks, that information wouldn't necessarily be available unless there was a different way that they were like receiving services.
Okay, great. All right, thank you. Looking in the Q&A, I don't see any other questions on this presentation, but I appreciate you going through that presentation and highlighting some of those key decision points for everyone. Our next presenter is the CHIA team. So we have Sylvia Hobbs. She's the Associate Director of Data Strategy and User Support. We have Deborah Gray. She's the Director, PMO and Business Requirements. And Isabel Caceres. She's the Manager of Special Projects. So CHIA team, take it away.
Sylvia Hobbs. This presentation is on assessing the reporting magnitude of social determinants of health Z codes in the Massachusetts Administrative Case Mix data for health services research. Decennial census zip code tabulation areas, known as ZICTA measures, of neighborhood attributes linked to healthcare data have been the classic tool for estimating the social etiology of patient healthcare risk. More timely data on the social determinants of health collected at the time of patient-provider encounter from intake screening are now encoded in ICD-10 CMZ codes, ranging from Z55 through Z65. Whenever I use the term Z codes in this presentation, I will be specifically referring to those social determinants of health in this range. Model performance metrics for healthcare data quality include completeness and consistency, specifically whether data are fully or only partially reported across time, care settings, and providers. Variation and gaps in provider uptake of ICD-10 Z codes potentially impact the reliability of Z codes for monitoring health risk. As part of quality review, we sought to determine the magnitude of reported Z codes in the Massachusetts case mix and charge data from the time of ICD-10 implementation through fiscal year 22. The 7 years of population-based data comprised of 22.9 million episodes of care from 15 million ED visits, 1.4 million observation stays, and 5.5 million inpatient hospital discharges. These data were compared by fiscal year, payer type, care setting, and by hospital coding patterns and by Z codes to understand variations in SOD Z codes. Variations of SOD OH Z coding for all hospitals, as you can see in figure 1 below, were ranked by top Z codes, and differences in the magnitude of the proportion of total patient populations with and without SDOH codes for both fiscal year and care setting. The figure 1 below simply shows you the entire volume of data that was used over the 7-year period. The ED had the lowest proportion of Z codes and HD the highest, as you can see in table 1 below. All three care settings had an increase in Z codes during FY 2020 onset of the COVID pandemic, as you can see in figure 1 below. While observation stay had the lowest volume of care episodes with Z codes, the proportion of observation stay Z codes consistently trended upward from an increase of 1.3% of all stays in FY 2019 to 2.6% of all stays in FY 2020. Looking at the ranking of Z codes, in ranking the frequency of all Z codes used by care setting for FY 2016 through 2022, homelessness unspecified, homelessness, and problems related to living alone consistently ranked in the top 5 Z codes for all three care settings. Unlike HD and observation stay, the ED had in its top ranking the granular Z code distinguishing unsheltered homelessness. However, unlike ED and observation stay, HD had a higher frequency of Z codes for a personal history of physical and sexual abuse in childhood. Even though the proportion of all records with Z codes is low, given the magnitude of homelessness Z codes used in all three care settings, we sought to validate the completeness of Z codes for homelessness against the case mix data existing homelessness indicator flag fill. All three case mix data repositories have an existing homeless indicator, which historically has a high completeness rate, over 99% populated using a yes/no flag to indicate whether the patient is known to be homeless. Evidence of potential undercoding for homelessness using Z codes was found when validating records with any subcode under the major Z code category for problems related to housing and economic circumstances for homelessness against the existing case mix patient homeless indicator. For ED and observation stay, less than 50% of records had a yes flag indicator for homelessness that had any Z59 subcode. HD had the highest percent of records with matching Z codes and ED the lowest. For all three care settings, it is noteworthy that the match between the use of Z59 subcodes and the existing homelessness indicator trended upward to the highest match during the onset of the COVID pandemic in FY 2020, as you can see in figures 1, 2, and 3. The limit was previously lifted in hospital discharge data and emergency department data on the number of diagnosis codes hospitals could submit in order to maximize the utility of the granular ICD-10 CM codes for risk adjustment. When comparing coding with and without Z codes for each year after FY 2017, when the use of Z codes began to surge, records with Z codes had a higher median and mean number of total diagnosis codes than records without. So in figures 1 and 2 below, the summary statistics show hospitals that had Z codes that for each year their median and mean of all diagnosis codes was higher than hospitals who did not have Z codes. But you will also see that there was a wider range variation in hospitals that did not collect Z codes, showing higher maximums. But the hospitals that did had more consistency in their reporting. In looking at insurance payers, while it has been previously reported that Z codes tend to be highest among Medicaid population, and the results of this analysis corroborate those findings for all three care settings, the surprise finding is that in the 2 years following the FY 2020 onset of the COVID pandemic, the reporting for payers coded as other, which include not-for-profit managed care organizations, which offers several types of insurance products for individuals, families, including senior care options, surpassed both Medicare and Medicaid in observation stay and inpatient discharge Z-code reporting. The highest reporting of any fiscal year in any care setting was 6.9% of other payer in FY 2022 inpatient discharge for Z-codes. The hospital-affiliated nonprofit health plans may be playing a positive role in overcoming both the provider level and patient challenges in collecting information needed to accurately report SDOH Z codes. As you can see in figures 1, 2, and 3 on the right, the gray bar represents the other health plans, which are the not-for-profit managed care organizations. These organizations also have some Medicaid and Medicare products and senior care option products. In conclusion, so we have results. In FY 2016, we saw HD showed that 91% of hospitals recorded Z codes and 2.8% of the patient discharges in FY 2022. This rose to 3.6% of discharges across 95% of hospitals. Additionally, FY 2022 HD highlighted a significant variation at the hospital level regarding the total diagnosis codes per discharge related to SDOH coding. Discharges with SDOH coding had more total diagnosis codes than those without. However, specialty hospitals, particularly those focused on pediatric burns and orthopedic surgery, did not report any SDOH Z codes. Turning to the ED in FY 2016, every hospital, 100% had SDOH Z codes, but this was only for a mere 0.5% of visits in FY 2016. This figure more than doubled in FY 2022. In conclusion, in all care settings, only a small proportion of patient records capture social risk using SDOH Z codes. Inpatient care facilities maximize the utility of all ICD-10 codes and had an overall higher total number of any diagnosis codes and a highest likelihood of using Z codes. Thank you.
Great, thank you. Looking at some questions. I see a question in the chat from the audience. Narissa Harvey asks, are the Z codes mostly found in primary diagnosis field?
The Z codes can be populated in the principal diagnosis and primary diagnosis field, but they are mostly found in the associated diagnosis fields.
Okay, great. I'm going to look in the Q&A tab. Brady, we're going to get to your question at the end. I know that was for Danny, but I see a question from Ernie Shippey, and he says, in your payer graphs, does Medicare include fee-for-service and Medicare Advantage, or is it Medicare Advantage in the other category?
Medicare fee-for-service and Medicare Advantage were all included under the Medicare because we use a coding aggregation where all Medicare products were aggregated together under an MC code.
All right, thank you. I'm going to pop back in the chat, see if there's any other questions from the audience. If not, I have a couple questions. So one of them is, have you thought about methods for validating the completeness of the Z codes for homelessness?
Yes, that was the sort of motivation for this presentation. We actually initially looked at Z codes in the APCD data, and I realized that for more than 10 years, we had this flag in the case mix data where hospital providers have consistently used a yes or no flag to indicate whether or not the patient was homeless. And we wanted to determine to what extent that aligned with the Z codes. And this allowed us to see for all of the patients that had a yes/no flag that there was underreporting of of the Z codes related to homelessness. But one of the things that was intriguing in the APCD, on the case mix side, we saw that inpatient care had a higher reporting of Z codes. When we looked at the APCD, we saw that that was also true, but ranking second was home healthcare organizations where visiting nurses and social workers potentially are the collectors of that data. So there may be some difference in the types of questions that the provider is asking the patient to collect that information. And that's something about the APCD and the home healthcare settings that warrants further study.
Great, thank you. One more question and then we'll move on to our next presentation. How did the COVID pandemic impact coding for social determinants of health?
We saw the coding go up during the COVID pandemic, especially in the outpatient care setting. There was a doubling of collecting that data. So the collection of data related to social determinants of health in all three care settings increased after during the onset and after the pandemic.
Great, wonderful, thank you. Great, I don't see any other questions. Oh, I see one question from Teresa in the chat. She asks, hospitals are struggling on where or who should be collecting it. It seems most successful when the discharge planners are collecting it. Has anyone else found successful process?
There have been papers done on who should be collecting this data and how it influences billing. Because in the hospital setting, there are armies of coders hired to maximize DRGs, and some of that information is collected directly from physicians. But when other care providers who are interacting with the patient after registration, like nurses or social workers, there has to be some change in the culture of how the narrative they collect influences coding and payments and incentives to pay and risk adjustment.
Thank you. Let's see if there are any other questions. Yes, I see one more question in Q&A. The question is, are you doing any outreach training with hospitals to increase reporting of SDOH-C codes?
The Massachusetts Department of Public Health, specifically the Bureau of Healthcare Quality and other agencies at DPH, work directly on providing training for hospitals on collecting sociodemographic data. In fact, I used to work at DPH and we had a specific training for different care settings, including ambulance providers. I had an intern who traveled with 30 different ambulance services, including air medical, going over training on collecting specific data. So our Department of Public Health does have some very specific training for providers on collecting social determinants of health data.
Great, thank you. Great, I'm just gonna take one back, look back through the chat, don't see anything. All right, well, thank you, Chia team. Our last but not least presenter is Alyssa Harris. She is the Senior Research Analytics Director at Vizient. Alyssa?
As Alyssa Harris, I work at Vizient, and today I am going to be talking about the creation of a unique social needs index called the Vizient Vulnerability Index to highlight drivers of health equity. The CDC defines health equity as a state in which everyone has a fair and just opportunity to attain their highest level of health. Health and health equity don't just occur within the walls of the hospital, and issues exist at all levels of society, from the interpersonal all the way to systemic, that contribute to health inequity. Some of the issues that impact inequity are within the control of a hospital or a payer to impact, and some are not, but all contributors to inequity must be addressed in partnership with communities. The challenge is that there is a lack of a comprehensive measurement of equity across all of these layers. So the challenge is How can we measure health equity? So to quantify health equity, vulnerability and deprivation indices have been developed. What they are composite measures of deprivation or vulnerability, typically at a geographic level, such as zip code, census tract, or neighborhood, that allow for ranking of socioeconomic disadvantage or deprivation. However, they are all created with a specific purpose in mind. So some may be more optimal for particular research questions or policy questions than for others. For example, there are some that are created for economic purposes and some that are created for health purposes. So what Vizient wanted to do was to create an index to address the needs for predictors of life and health outcomes that adapted down to the local level for the particular local drivers of life expectancy and health outcomes. On this very information-dense slide, you can see 6 different indices created to quantify equity. Because they all have different intended measurement focuses within that equity space, they are all comprised of different information and measure things very differently. So they have different levels of data granularity, the unit they can get down to. They're updated at different frequency. Within the domains of social determinants of health, there are some that include some of the domains, some that include more, and the Vizient Vulnerability Index includes all 9 of them. The healthcare focus is different, with some that are not created for healthcare focus having no relevant focus within the index. If you look at the measurement focus, the Vizient Vulnerability Index was created to measure differences in life expectancy. But if we try to apply some of these other indices to life expectancy, you can see that that fit is not ideal for that. So, for example, the Area Deprivation Index, which is intended to predict mortality, only has a moderate fit to life expectancy with an R-squared of 0.4. If we look at the Inner City Hardship Index, which is intended to describe economic differences, when we try to fit that to life expectancy, the fit is poor with an R-squared of 0.14. The Vizient Vulnerability Index is intended to describe the differences in life expectancy and is fitted for that. So with that flex at the hyperlocal level, there is an R-squared of 0.75. Additionally, and most excitingly about the Vizient vulnerability is the difference at the geospatial level. The other 5 indices that are presented only have a single algorithm for the whole country, where the Vizient Vulnerability Index adapts at that local level to each domain as it corresponds to life expectancy. So it has the ability to fully quantify and prioritize the inequities that communities are experiencing. In one geographic area, the most critical issue might be food deserts. In another, it could be environmental conditions like living next to a Superfund site, or public safety, or housing, or access to care, and the index flexes to that. So the resulting index describes how social determinants of health drive life expectancy in communities and can be applied to several different health-focused outcomes, particularly related to chronic disease incidence and management, readmission rates, ED utilization, and maternal well-being. The Vizient Vulnerability Index also excels in its measurement focus, compared to some commonly leveraged indices, in knowing exactly what issues are affecting local residents, health systems, and local governments, so they can gain perspective on possible resources or partnerships necessary to better support their patient population and citizens. So ultimately, it provides a multitude of different touch points for healthcare organizations and beyond to understand their community and where the gaps exist. Other indices simply don't allow for that same level of specificity. Beyond providing context for patient-centered longitudinal views of outcomes, the Vizient Vulnerability Index is free and it is publicly available. It has been developed to characterize those neighborhood factors that might influence patients' healthcare access and opportunity for their health goods. It is intended to be paired with clinical data by that patient's zip code or census tract level in order to evaluate relationships between clinical outcomes and specific neighborhood vulnerabilities, and to identify interventions that address the actual relevant vulnerabilities to that specific neighborhood. The Vizient vulnerability enables social needs to be quantified at the local community level. And what that means is the 9 domains of social determinants of health are all flexed at that local level in order to flex to what is most predictive of life expectancy at that particular census tract or zip code level. What the 9 domains are economic, education, healthcare access, neighborhood resources, housing, clean environment, social, transportation, and public safety. And there is a score for each of these domains that is present at each of those levels, so you can use each domain individually as well as use the aggregate Vizient Vulnerability Index in order to quantify needs. The data sources for the index are all publicly available, listed below, but they come from a variety of different sources. mostly government data. This map of the US shows the geographic distribution of the Visian Vulnerability Index, with those darker red areas indicating more vulnerable areas. So you can see regional distribution, with the darker red really being predominant in the South and less vulnerable areas in the Midwest and West. But even within the regional level and the local level, you can see differences. If you look at that zoomed in area, which is the city of Chicago where I live, you can see that the north side of Chicago is much less vulnerable than the dark red south side of Chicago. And it aligns very well with the map of life expectancy. This is the CDC life expectancy map. And you can see similar patterns where the darker red areas are very prevalent in the South compared to more blue regions in the Midwest and West. This slide has taken 5 hospitals within the same city and looked at the distribution of the vulnerabilities of where their patients are coming from. As you can see that even though they are in the same city, the vulnerability of the neighborhoods of those patients are very different, with some having very vulnerable patients, predominantly vulnerable patients, some covering the whole spectrum of vulnerability, and some predominantly treating less vulnerable patients. And this can be a useful comparison tool when you're trying to figure out where your patients are coming from and their vulnerabilities. If we're looking at these 2 hospitals, Hospital X and Hospital Y, you can see on the graphs that their patients come from very different areas of vulnerability. Hospital X has 0.1% of their patients from zip codes with a Visian Vulnerability Index value of greater than 1, compared to 67% at Hospital Y. And with that, the way their patients present and their chronic diseases and their hospital utilization looks different. At Hospital X, they have a lower proportion of adults with type 2 diabetes, 8% compared to 14%. Of their patients with diabetes, more patients at Hospital Y have an A1C greater than 9. More patients at Hospital Y also use the ED or had an ED encounter in the last year, so 18% compared to 45% at Hospital Y. There are also more patients with behavioral health diagnoses at Hospital Y, 34% compared to 21% at Hospital X. And for the payers, there are more payers that have Medicaid or are uninsured at Hospital Y, 67% compared to 27%. So at Visiant, we've taken the Visiant Vulnerability Index and applied it to our own data and have found significant relationships to existing measures. And neighborhood vulnerability is correlated to differences across the continuum of care. The most notable differences are not actually in the acute inpatient encounter, but outside of them, in the chronic disease incident and severity, complications of chronic diseases, ED utilization, and readmissions. Here is an application of the Visian Vulnerability Index for one particular hospital in their diabetic patients. You can see in the purple map the incidence of diabetic patients coming to that hospital with type 2 diabetes, and below it the Visian Vulnerability Index of those neighborhoods that correspond to it. And you can see that there is a correlation between more patients with type 2 diabetes and more vulnerable neighborhoods. Beyond being able to look at the Visian Vulnerability Index level, you also have the ability to go to the domain level to look at associations. So for this example, it is looking at the association between diabetic patients from neighborhoods with a food desert and their rates of A1C greater than 9. And you can see there's a positive association with more vulnerability and higher A1C rates. And with that, the Visian Vulnerability Index is really aimed at identifying actionable interventions and identifying specific obstacles to care and the social needs related to poor health outcomes, so that interventions can be targeted specifically to those obstacles and needs. So where do you get this index? There's a link to the website that we have it at, but if you just Google Visian Vulnerability Index Public Access, you should also be able to go to the website and download it. And thank you for your time.
All right. Thanks, Melissa. Great, awesome. Okay. So let's look. I'm just going to look in the audience and see if there are any direct questions in the Q&A tab. Looks like none yet. So I had a question for you, Alyssa.
Yeah.
Why isn't race included as a domain in the index?
That's a good question. It's very purposely kept out of it because it's not something that's modifiable. It is something you can act on, and we were very intentional in only including things that were actionable in the index. Race, of course, has a lot of intersection with a lot of the social determinants of health. But as far as things that we can modify, that is what the focus of the index is.
Okay, great. All right, thank you. Are there any other measures that are being proposed for inclusion?
Yeah, and we're open to suggestions of other metrics that people think might be good to include. We have a running list of things that we're planning to test and incorporate. Some of the ones that are on the list right now are broadband availability, opioid dispensing patterns, primary care availability, segregation, and some other EPA measures like water quality and air quality as well. So if anyone has any suggestions of things that they think would improve the index, we are very open to looking into them.
Great. All right. Thanks, Alyssa. I see a question in the Q&A from Ben Chan. How can the vulnerability index be used to characterize a collection of geographic areas? So, for example, Zach does in a service area.
Yeah, so if you can attach them to a patient, if you have a group of it's really meant to be attached to a patient level and then aggregated. So you can use it as an index to say, the average vulnerability of an area, or in vulnerability to look kind of at the distribution of how that looks. You can do it at the ZICTA or the census tract level. So it really, the intention of it is to be used either to look at, as a modifier, see how your patients look different, or to characterize patients based on their vulnerability. It can be used as a covariant in analyses to see, and as a kind of a demographic characteristic as well.
Great, thank you. Another question from the audience. Rangi asks, have you studied the correlation between the Vizient index and others, like the other indexes?
Yes, we have. So really what the Vizient index was meant to do is predictive of life expectancy. And for that is where we focused our correlation. It's highly correlated at specific domains to others. So the correlation of the Vizient vulnerability index in life expectancy has an R-squared of 0.75. And then others have different. So the area deprivation index, for example, has an R-squared for life expectancy of 0.4. But that's really driven, those are driven by the income and housing domains of social determinants of health. So those within the Vizient vulnerability index are highly correlated to those domains within our Vizient vulnerability index.
Great, thank you. We have another question come through. Santos Washington asks, does it make sense to compare the data to food swamps as well as food deserts?
That's a good idea. I think that you probably want to pick one and go with that, just to not kind of muddy that. But I think that's a good way to look at it as well. I think they're very related metrics. So I think that would be a good thing to look at.
Okay. All right, I'm just going to check into the chat. I don't see any questions there. All right, so I think we can bring the group back on the screen. We have about 10 minutes left for a group discussion. I would like to go back to a Q&A that I think was related to Danny's presentation that we missed from Brady Rice. So since Danny's here, we'll bring that up. So the question was, what other SDOH variables have you developed a methodology to assign besides race ethnicity?
Well, in my current role at HSRI, I've only developed methodology for race and ethnicity for that person directory, but the person directory, we have different teammates that have been responsible for different elements of it. It contains like date of birth, it contains first sex and recent sex. And we're definitely open for other areas or different demographic domains that should or could be added to it. It's something that we have a great partnership with Karen Lee at MHDO, and it's something that we really hope to continue to expand upon.
Great, thanks, Danny. One other question in the Q&A for Alyssa came through. It says, are previous years past data of the index available?
They are not, because it's a new index. So it just became publicly available in July. So we only have this current version, but it will be updated on an annual basis moving forward.
Great, thank you. Okay, I'm just going to check the audience chat. I don't see anything else there in the Q&A. So a discussion question for the group. Based on your experience, what are the greatest challenges to missing and incomplete SDOH data, and how do we mitigate those challenges? Feel free to jump in, whoever would like to start.
I think, like Sylvia highlighted, the inconsistent collection is a really huge barrier to how we can use them. I think hospitals with more resources and more directives to collect them are more likely to have them. And those are probably, hospitals, larger hospitals with more resources. So we're less likely to get that data from smaller hospitals that don't have the resources to collect them. And the data availability in the EMR doesn't necessarily always translate into a claim because it doesn't impact reimbursement. So I think if we can continue to emphasize the use and the value of these codes, then maybe we can make a case for having them included more, and showing that social determinants of health codes, like comorbidity codes, are relevant to a person's health. I think that might make a better use case, that people might include them more.
Also, in terms of the all-payer claims data, if you take the case mix data, which has, for example, generally really good race and ethnicity data, and you turn around and look at the claims and see that data disappear, I think some of the payers in the private sector need to develop a business need and analyze that data and appreciate the importance of it the same way some of the public payers have. And as I mentioned, I think Boston Medical Center, HealthNet, their new nonprofit insurance product, collects social determinants of health at a high level because they are interacting with community groups and have projects related to the use of that data.
Great, thanks, Sylvia. Yeah, Danny, go ahead.
I was just going to say, I have pretty much the same answer as Alyssa in the limitations with Z codes and claims as a whole. But since I know, like in the APCD world, it's primarily reflective of what basically gets reimbursed for. Until we have better SDOH data within those data sets, data linkages like what Vizient has done, I feel like is like a good starting point for this kind of work.
Okay, great, thank you. I don't see any questions from the audience in the Q&A. I had another question. So let's say, or actually I just saw one come through from Carrie Frank. The question is, we've heard there are provider concerns for using Z codes when the notes EHR are shared with the patient. Providers in Colorado have said it seems like a judgment against the patients in some instances. Have any of you heard of this barrier?
I think one of the issues becomes anything that you say about your medical condition becomes a part of your medical history, and there may be some concern on the patient and how they're perceived and having some of the bad things that are associated with that can impact your health being transparent on reporting that, and the providers having the right data collection tools to record that information and not have it impact your impression of the patient. But I have heard of that.
Any other thoughts for the group?
I haven't heard that specific to the Z codes, but I have heard it around how physicians put together their notes in general. They take a lot more time now. They are a lot less anecdotal in what they're saying, and it's a lot more formal, and losing a lot of nuance because they know that it goes to the patient. So I'm not surprised to hear that. I think if there is a way that we can kind of reduce the stigma around it, that would be good, because they're so valuable to use. And really the purpose of collecting them is in theory to connect the patient to resources.
And more now, patients have the option of their EHR systems of going in online and seeing whether the clinical notes are accurate. I think that came up in the opening session of unblocking this information so the patient can make sure that it's reflects accurately what they are and who they are at times, because some patients are shocked when they look at what doctors have actually written about them.
Yeah, great. Thank you. I saw another question come up in the chat. Following up to Chia's finding that homelessness is the most prevalent Z code, does Chia or others on the panel have insight on why other Z codes are less prevalent, e.g. providers are not trained to recognize the SDOH issues, or do not have enough time to understand patients' SDOH needs, or do not have the right instruments to get this info?
Yeah, homelessness is going to be the most prevalent because it impacts where you send a claim, where you get your bill. So that seems to be the most prevalent by far for that reason. As far as the other codes, it really depends on how they're being queried for the information. So there are some things that are just more commonly asked questions than others in those Z codes. So if you don't ask the question, you're not going to get the answer in order to even translate that into a Z code.
But what we did see that we hadn't seen in any publications related to Z codes was in the inpatient care setting, the history of child abuse and sexual abuse as being one of the top codes collected in the inpatient setting. And that's something that requires more study, and it would be of value to know whether in those specific hospital settings, social workers play a higher role in reviewing clinical notes in those cases.
Thank you for that. All right, so we have about 4 minutes left in this session. So I think I'm going to ask another question to the group, and then we'll wrap up the session. So question for the group: if there was an analyst working with like a state APCD who is interested in starting to report on SDOH factors, you know, what advice would you give to them? Like, where should they start? What indices should they be reviewing? You know, what anomalies should they be thinking about, like with the data and missingness, and how to evaluate missingness? Just any advice you have to analysts who, you know, want to start out reporting SDOH from APCDs and where they should go.
The tried and true method that we see most applicants for the Massachusetts all-payer claims data doing is they request the 5-digit zip code, and they link that to the decennial Census American Community Survey data, which provides area measures related to social determinants of health. And that has been the geographic information is reliably reported, and that's been what people have that's been the fail-safe for garnering that information.
Yeah, adding to that, Massachusetts has now the zip code level information, but it could be well used the census tract or the block group to get the population, area-based population in those geographic areas, to bring that into the patient level. So Massachusetts is limited to zip code, but I don't think it's the only geographic area to be used.
Something I would suggest to an analyst is attend a conference like NADO, where there are people that are similarly using APCD data and other kind of data sets that also have social determinants of health focuses. and just seeing what they're doing with their data and how they're diving into it and what their analytics are. I think that is a good place to start, so you're not recreating the wheel. Other things to look at are, CDC, Healthy People 2030, other public health initiatives to see what their focuses are, and then starting to think about how you can translate that into the data, or what you might want to link to the data that you do have in order to inform it.
Thank you. Great. All right. Thank you. So we have about a minute left. I think we should probably wrap up in the interest of time. So to the audience, if you're interested in further discussion on this topic, there's a health data deep dive on social determinants of health coming up tomorrow at 2:20. And on Thursday, there's another advancing health equity session from 1:10 to 2:20. So hope to see you all there. And thank you so much to our presenters. Thank you to the audience for your time and attention. Norm said there was over 250 people attending this session, which is wonderful. So thank you so much. We appreciate you. And that concludes today's session. Thank you. Have a great day.